Okay, so now on this page, what I want you to write is that pulse ox less than 90. I want you to write that.
On this page?
Yep, that front page, because it says hypoxia, right? So that makes sense. So pulse ox less than 90. Then I want you to write ABGs. SaO2, skip a little space. SpO2, skip a little space. PaO2, skip a little space. And PaCO2. So here's what we're saying. We're basically telling you that you have to understand all of these values, if you will. When we talk about pulse ox less than 90, a pulse ox is indirect. You didn't draw any blood. It was indirect. The value that coincides with the pulse ox is this one, SpO2 less than 90. The way you're going to know the difference is if it has a little bitty a, it means blood was drawn. SpO2 does not have a little bitty a. If it has a little bitty a, that little bitty a stands for arterial blood was drawn in your mind. So ABGs all will have a little bitty a. Okay? Now, a pulse ox less than 90, you should know by now, is a medical emergency. The pulse ox less than 90, or SpO2 less than 90, is going to have the exact same measurement, even though it's different, as SaO2. An SaO2 and an SpO2. What are the differences? Sp is indirect. Sa, I drew blood. But there's still a freaking O2. S's, both of them. Okay? Now, if the pulse ox or Sp or Sa, which is blood, drops below 90, and you're stuck on stupid and parked on dumb and allow for that shit to continue because you listen to your teacher or your preceptor tell you that COPD drops below 90 all the time, sorry, you were taught wrong. But if you allow that hot mess to continue, considering that even our COPD patients have to stay above 90, not to mention they're on oxygen. So no, that wasn't true that they're allowed to pulse ox below 90. I don't give a crap who tells you that. That is absolutely not true. But if you were stuck on stupid, parked on dumb, and allowed this shit to continue, your patient eventually would drop their PaO2, which is not ventilation. This is perfusion. So the P in your mind, not technically, but in your mind, you're going to say, oh, that is actually oxygen to my tissue. That's perfusion. The S's are oxygen to my lungs. That's ventilation. So when your ventilation can't keep your SpSaO2 above 90, your perfusion is going to suffer. It's going to take a while for all of that to go down, but it's going down. So what we tell all nurses is that when you do walk in the room and a patient is having a hard time and you put the pulse ox on and I don't give a shit what kind of patient it is, COPD or otherwise, and their pulse ox drops below 90, and you see it clearly, if you don't act on it and do a lot of things fairly fast, then we're going to actually affect the perfusion in the body. If a patient can't bring their pulse ox above 90, despite the things we're going to talk about that you do to them today, then they need mechanical ventilation. As it is, no matter who it is, even COPD, when you have a pulse ox less than 90, your first nursing action is oxygen at 10 to 15 liters. I don't care about the COPD part. I didn't say maintenance dose, I said resuscitation dose. So 10 to 15 liters is your first nursing action. When you walk in the room, there seems to be some, hard time breathing. You did the pulse ox. Hey, it's below 90. Kick in emergency mode. Slap them upside the head with that oxygen mask. Put it at 10 to 15. Anticipate sitting them up. Semi-Fowlers, right? You guys know. Semi-Fowlers are even higher. Anticipate some suctioning. Maybe that's their issue. Tell them to cough and deep breathe. So you have a lot of things we're going to teach you that you kick into automatic mode. People die from COPD, not from COPD, but from idiots who were taught it's okay for them to pulse ox below 90. And there's a lot of people taught that. So you're not going to do this shit. You're going to go in here, you're going to kick in automatic mode, you're going to kick in your little emergency actions that we're going to talk about, and you're going to understand that when the SP or the SA, when the actual ventilation, SP, SA, ventilation drops below 90, now our PaO2 is going to follow. And let me show you what that means. You guys probably know that an SA, a pulse ox, the SP normal is 95 to 100. Is that safe to say you all know that already? Yeah. Okay, so we said below 90 is a medical emergency. We ain't too keen on 90 though, are we? But we're talking about less than 90 is a medical emergency. So far so good? Okay, now normal, this is one of the most important labs on the board, normal PaO2 is 80 to 100, and when you ignore a pulse ox less than 90, you drop this down below 60. So your medical emergencies are pulse ox less than 90s, PaO2s less than 60. So far so good? When either of these is going on, and the only way to tell PaO2 was how again, everybody? Yes. The only way to tell a PaO2 was to draw some blood. So arterial blood gas. That was the only way you could even imagine what this was, is that you drew blood. Normal is 80 to 100. Outrageous is less than 60. When does a patient need a ventilator? Come with your girl. When the PaO2 rides around 50, we're going to need a ventilator. Now, the first sign of hypoxia and the sign that you should go crazy in your patient. So the first sign of hypoxia and the first sign that you should go crazy in your patient's room, making sure you do all kind of emergency features, is when your patient has a behavioral change. On your sheet it says restlessness. I teach you that restlessness equals respiratory distress. That's a song we sing, okay? So restlessness is the worst thing possible you could see. It's one of the earliest things you're going to find. It's trying to tell you this patient is going out, okay? So my ICU nurse who came in here and talked to the class, she said, Shelly, they had a patient with restlessness, agitation, confusion, all of that shit going on, and they gave him freaking Ativan. He was having a stroke. You have to act fast when patients are confused, agitated, restless, anxious. All of those are behavioral terms that will change first, and then comes all the rest of the hot mess. What comes after that? You see it on your sheet. Tachycardia. You can see anxiety is yet another word for the same damn thing. So you have two behavior words. Now take your pen or marker or whatever you got and cross off, literally cross it off. Cross off bradycardia. I don't want you ever to think of that for this patient, because I want you to always remember bradycardias go with neuro patients. And it just doesn't make any sense for you to confuse your little brains right now. Now, so your patient will have a lot of things going on. Some of my NCLEX students are here today, and yes, you are being put on the spot, so suck it up. What is it the patient's going to have? They're going to have a hit it, pulse ox less than 90,
BO2 less than 60, grunting, flaring, retracting, tachy.
What does tachy mean for them? Tachycardia and tachypnea, both. They're going to have both. What else? Shortness of breath and dyspnea. Okay? Honestly, that's it. The worst thing is the last word of the song. What is it, you guys? Restlessness. It's respiratory distress. Honestly, make sure you know the song. It's pulse ox less than 90, PaO2 less than 60, grunting, flaring, and retracting, which I think is at the bottom of your page. Grunting, flaring, retracting. Some of that is at the bottom. Tachy, which is tachycardia and tachypnea. Shortness of breath and dyspnea. So dyspnea is probably already on your sheet. It means the same thing as shortness of breath. This is your medical emergency. Now let's use this sheet to say what the hell you're going to do about it. First nursing action, what do we say? Slap them upside the head with oxygen, right? Okay, so put O2 down, because we got 10 things. 10 things you better do. Oxygen. And remember in your notes for this exam, increase it to 10 to 15 liters. This is not no piddly little dose. No, you're trying to resuscitate this patient. So 10 to 15 liters. That's number one. This is not going to go in any order after number one. It's just all the things we do as nurses. Sit them up. So position change. Position is number two. You could have said something else for number two, but that's fine. Position is number two. In other words, it's not in order after number one. So position, this is semi-Fowlers or higher. Semi-Fowlers or higher. Suction, that's number three. Suction is number three. Number four, bronchodilators. Bronchodilators as ordered. What number is that, babies? Some of y'all got 5, some of y'all got 4. How fucked up is that? So what is number 1? Okay, good. Okay. Number 5, cough and deep breathe. Cough and deep breathe. Number 6, chest physiotherapy. Chest PT. Chest physiotherapy. Number 7 or 6. Is it 7? 7. Good. Change the patient's mask to non-rebreather. So change the mask to a non-rebreather, because that one gives you 100%, right? Increase IV fluids is next. If you increase the IV fluids, you thin the secretions. Assess for pain. Maybe that's why they got their underwear in a bunch, because they're actually in pain. Assess their pain level. What level are we okay with? 3. We're not okay with anything above 3. So assess their pain. If we are in true respiratory distress as evidenced as a pulse ox less than 90 and a PaO2 less than 60, you better not leave that patient. You can call out for help. You better not leave them. Stay with the patient. True respiratory distress means you stay with your patient. Yeah, that should be 10. Is it 10 now? Yeah. Now, again, my nurses leave out of here and they kick that shit in so fast that the recruiters call for them immediately because they are the shit. They know these like they know their name. They understand it. They get it. You don't want to fuck around with this shit because here's what I'm going to tell you. Watch this. It's almost amazing the way this works. Here we go. Everything I'm going to teach you today started with the respiratory song. A respiratory song, pulse ox less than 90, PaO2 less than 60, grunting, flare, retracting, tachy, shortness of breath, dyspnea, and restlessness. If I add this patient's right here with the pulmonary embolism, if I add the fact that they have chest pain and hemoptysis, I made it a pulmonary embolism. Pulmonary edema, if I add pink frothy sputum, I made it pulmonary edema. Pneumothorax, if I add tracheal deviation, I made it a pneumothorax. If I add chest pain and a clot, it's pulmonary hypertension. If I gave them oxygen and their pulse ox didn't budge, it's ARDS. I go all the way down the list. It's not up here because it's not on your exam. It was on 1600. But if I wanted to, I could throw asthma up here and I could say that this patient has a respiratory song and they also have expiratory wheezing. That made it asthma. So it's my job to teach you the song and help you understand what you're supposed to do with the song, and then we're going to fix all this crap with a couple of different things we add to it. Okay, so when we're looking at the next page, it talks about your role in this patient and how you would manage the patient who is dealing with hypoxia. This guy, as you can see, has hypoxia written on his shirt or whatever it is. And if you look at the top, it talks about the fluids, it talks about the suction, it talks about cough and deep breathe, it talks about reposition. Do y'all all see that? Now, this patient is a respiratory patient. I want you to highlight what I think it says on your sheet, which is that all of these things together are called pulmonary hygiene. Do y'all see that? Pulmonary hygiene is what that's called. Sometimes people call it pulmonary toileting because you're flushing the patient away from all this congestion, but pulmonary hygiene, pulmonary toileting. If you look on the bottom and you see it says early versus late on the right-hand side, does everybody see that? I want you to remember it says restlessness on both sides. Y'all see? And then there's your tachy. There's your dyspnea. One thing I always tell you to add to all of these emergencies we talk about today and Monday is the patient sweating profusely. In other words, we got diaphoresing. People who are sweating are in distress. Okay, so they're sweating. Notice the behavioral term of agitation. Okay, so there you go. We've got a lot of shit here. Now, if you go on the right-hand side, you'll see pulse ox. Everybody see that? What does it say? Less than 90. Highlighted. Pulse ox less than 90. Right up above the chart. Right above that early, late chart is pulse ox in 90. Now, ABGs. You got a little space there that says ABGs. Let's just make sure we know our shit on ABGs. Before I can do ABGs, which is arterial blood gases, what do I have to do first? Allen's test. Amen and hallelujah twice. So when we do an Allen's test, this is the best trick you're going to remember. The best trick you can remember is that a negative Allen's equals no way are you doing ABGs. So a negative Allen's equals no ABGs. That makes sense, doesn't it? Okay, so here's what I'm trying to tell you. Let me make sure you're clear. This little girl, I'm going to do a ABG on this little girl here. I go in the room, I'm going to take her little hand, and I'm going to tell her to make a fist. Ain't that right? Okay, she's going to ball up her little fist. I'm going to take these two fingers, and I'm going to press on her artery in both the radial and the ulnar areas. Now, what I'm doing, which I'm not right now, but if I was pressing really kind of firmly, I am trying to occlude the blood flow to this little fist of hers. Now, the reason why you care is because when we do an ABG in that radial artery, we can damage something so bad that there's no longer a radial artery that is working on this patient. What backs it up or has collateral circulation? The ulnar artery, but not if the shit didn't work in the first place. So what I'm doing is I'm checking for, quote me, collateral circulation. Collateral circulation. I'm making sure if I poke her in that artery and I damage it, which is a risk, that she still has a way to circulate the fist. So I occlude those two vessels, right, the arteries on both sides, and then I say, open your fist, sugar. And she opens her fist, and then I take my fingers off the one artery, and her fingers will fill up. They'll just completely fill up with blood flow. It'll be pink like before, yada, yada, yada. If she's okay, of course. If she's not, guess what? You're not going to do no damn ABGs. You're not going to do an art line. Remember that for the exam as well. The art lines don't get done. ABGs don't get done because ABGs and art lines are done the same way. Okay, so no art line, no ABGs if there's no circulation, no collateral circulation. Okay, all right, so that's that. Now let's look inside of the packet till you get to something that says pulmonary embolism.